So thanks, Dr. Haas, and thanks to the Nicholson Foundation for hosting this event. And thank you to all of you for being here. As Dr. Haas said, I'm a medical oncologist primarily treating GU cancers here at Penn. And a lot of what you've heard thus far today has related to clear cell kidney cancer. But I'm going to try and in 15 to 20 minutes present a bird's eye view of the past, present, and future treatment of non-clear cell kidney cancer. So as some background, the way we think about kidney cancers has historically been grouped into two major subtypes. The vast majority being what we call conventional clear cell kidney cancer, which comprises about 75 to 80% of all kidney cancers. And our pathologists, when they look at it under the microscope, see these cells with this central clearing in each of the cells. On the other hand, there's the remaining forms of kidney cancer have been historically grouped together as non-clear cell kidney cancers, and this comprises about 15 to 20% of the remaining kidney cancers. And within non-clear cell disease, there's several major subtypes, including papillary type 1 and type 2, chromophobe kidney cancers, unclassified kidney cancers, and then several additional less common subtypes such as translocation, medullary, and collecting duct tumors. In addition, there's a variant called sarcomatoid kidney cancer, which can actually be admixed with any of these various RCC subtypes and generally portends what tends to be a more aggressive clinical course. But what I would really like to emphasize today is that our understanding of the treatment of non-clear cell disease has clearly been evolving over the last several years, where instead of viewing this as a single uniform entity, we've begun to appreciate that this actually represents a spectrum of different diseases, all with distinctive molecular and genetic alterations, differing clinical courses, and variable responses to treatment. So historically, in the past, the majority of the initial studies for the treatment of kidney cancer evaluated agents specifically for those patients with clear cell disease. And again, this represents the vast majority, or 80% of patients. And unfortunately, we've had little consensus as a community regarding the best treatment practice for those patients with non-clear cell disease, or that remaining 20%. And so, for example, if we look at our national treatment guidelines for those patients with clear cell kidney cancers, we see these very well-characterized and well-defined treatment options for patients with favorable, intermediate, or poor risk disease. So we have many options to choose from. On the other hand, if we look at those same treatment guidelines for non-clear cell kidney cancers, we see a lot of empty space, largely because we don't have a strong evidence base to inform our optimal treatment options. And historically, there's been two randomized trials that evaluated systemic treatments specifically for non-clear cell disease. And these were called the ESPN and ASPEN clinical trials. And both of these were relatively small, randomized trials. The ESPN trial with 68 patients, and the ASPEN trial with just over 100 patients. And these two trials compared head-to-head two agents that you've heard about earlier today, sunitinib, a VEGF inhibitor, and everolimus, an mTOR inhibitor. And the reason these two drugs were chosen is that they had already been shown to be effective in patients with clear cell kidney cancer. And so now the goal was to see if we can extrapolate those treatments to those patients with non-clear cell disease. And these are Kaplan-Meier survival curves, and as Dr. Plomek nicely described, these are essentially descriptive analyses on how patients do over time. And looking at these curves, both with the ESPN trial and the ASPEN trial, we saw a suggestion that those patients who were receiving sunitinib fared slightly better than those who were receiving the mTOR inhibitor everolimus. And so our conclusion from this work was that VEGF-directed therapies became the de facto standard treatment for non-clear cell disease, although recognizing that we were extrapolating from the treatments for clear cell disease, and we recognized that these were overall modest clinical outcomes. So moving to the present day, we've begun to change our thinking in terms of how we think about non-clear cell kidney cancer, where instead of acting as lumpers, we've begun to think more as splitters and recognize that this is truly a heterogeneous disease group, where each subtype bears a distinct biology. And this has led to an improved understanding of the molecular underpinnings of each subtype, as you heard from Dr. Srinivasan earlier today. And this includes the defining characteristics based on chromosomal alterations, tumor metabolism, among other molecular and genetic changes. And a lot of this improved understanding has come from a variety of collaborative projects, the largest of which was the Cancer Genome Atlas. And this was a collaborative endeavor that sought to create comprehensive maps of the key genomic changes in various cancers. And in fact, over the last decade, we've had a variety of landmark research papers that have characterized clear cell kidney cancer, as well as some non-clear cell subtypes, including papillary kidney cancer and chromophobe kidney cancer. And we've begun to improve our understanding of these various tumor types. So in clear cell disease, as you've heard earlier today, we've recognized that some of the prime oncogenic events are, for example, inactivation of a tumor suppressor gene called von Hippel-Lindau, as well as many other mutations in chromatin remodeling pathways, among others, that lead to the development and progression of clear cell kidney cancer. On the other hand, as you heard, with papillary kidney cancer broken up into type 1 and type 2, we've seen that there's activating mutations and alterations in the MET proto-oncogene, which can lead to the development or progression of type 1 kidney cancer, as well as a variety of different alterations that are different in type 2 kidney cancer, papillary kidney cancer. And finally, in chromophobe kidney cancer, a variety of mutations, including alterations in what we call the TERT promoter region, changes in mitochondrial function, among others. And so certainly, we wouldn't want to memorize these lists, but I think it illustrates that there are areas of overlap with clear cell kidney cancer, but also some very important and unique differences with each of these subtypes relative to the conventional kidney cancer. So as we start to think about how we use this information to improve the treatments for patients with non-clear cell disease, we're really starting to have a change in treatment paradigm, where instead of simply extrapolating treatments from clear cell kidney cancer and testing them in non-clear cell patients, it would be ideal to have biology-driven clinical trials that assess specific treatments for specific non-clear cell subtypes. And this certainly won't be easy, because on the one hand, we'll have significant challenges with trying to accrue patients for what are generally uncommon kidney cancers. But on the other hand, we stand to derive great benefit from testing these rational and biologically driven treatment strategies in patients that have hopefully a more uniform biology. And this will really involve very collaborative efforts. So I just wanted to give some examples of how this is starting to be done for patients with non-clear cell disease. And this is one example of an international or North American study looking at specifically papillary kidney cancer, both type 1 and type 2, and this sort of is based on the premise of what we heard earlier today about this idea that this MET oncogene is involved in the promotion of papillary kidney cancers, particularly type 1. And what the study seeks to do is use 3 different MET inhibitors, so the drugs cabozantinib, savolitinib, and crizotinib, and test them against the de facto standard treatment, sunitinib, the VEGF inhibitor. And more recently, this has become essentially a 2-horse race between the drugs sunitinib and cabozantinib, and this study is nearing its full accrual, where hopefully we'll begin to determine whether this might be a viable approach. I know in a lot of the pre-symposium questions, a lot of people had questions about immune therapy for non-clear cell disease. So I wanted to spend a few minutes on that. We've heard so much about how immune therapy has become such an important component of the treatment of clear cell kidney cancer, but what about non-clear cell patients? So this is some retrospective data from a couple years ago now that looked at the use of immune therapies or immune checkpoint inhibitors in a variety of different patients, both with clear cell and non-clear cell histologies. And this is what we call swim lane plots. So this is basically showing individual patients in each row and how they do over time with the treatment with immune therapy. So the longer the line extends, the longer patients are able to remain under control with these forms of treatment. And we can see that, as we might expect, we see some responders in clear cell histology. But we've also seen some benefit in patients with non-clear cell, particularly papillary and unclassified non-clear cell histologies. And we're now beginning to see some prospective trials looking at this in non-clear cell patients. So this is one example from earlier this year, what we call the Keynote 427 study, where it took the immune checkpoint inhibitor pembrolizumab and tested it in patients with non-clear cell kidney cancer, over 160 patients. And this was primarily patients with papillary kidney cancer, but also some patients with chromophobe and unclassified. And they saw some response. So especially in patients with papillary and unclassified tumors, we saw response rates that were respectable for this form of treatment in these patients with non-clear cell histologies. Less so in those patients with chromophobe, although overall small numbers. And this is what we call a waterfall plot, which shows how much are tumors growing above the horizontal line or shrinking below the horizontal line, with each column representing an individual patient on this therapy. And we can see that there are a significant number of patients who appear to be having shrinkage of their tumors with immune checkpoint inhibitor therapy. And this includes patients with a variety of different non-clear cell histologies, but again, predominantly the green and the purple shaded bars, so the papillary and the unclassified. And then I wanted to highlight one particular variant, which is the sarcomatoid kidney cancers, because this is one area where immune checkpoint inhibition has definitely gained a stronghold for the treatment of these patients. And so this is data from one of the largest randomized trials looking at a combination immune therapy approach versus the standard VEGF-targeted agent sunitinib. And again, these are waterfall plots showing tumor growth or shrinkage. And we can see with the combination immune therapy approach, these patients with sarcomatoid kidney cancer appear to have a significant amount of tumor shrinkage relative to the VEGF inhibitor. Unfortunately, this shrinkage in tumor translates into what we care about most, survival benefit. We're looking at intermediate and poor risk patients, again with this sarcomatoid histology. We see significant survival improvement in those patients receiving the combination immune therapy relative to those patients receiving the VEGF tyrosine kinase inhibitor. So in conclusion, in thinking about the treatment of non-clear cell kidney cancer, especially as we move to the future, it's clear that our understanding of this disease is evolving. We know now that non-clear cell RCC represents unique subtypes with distinct molecular alterations and varying clinical courses. And we're beginning to understand through things like the Cancer Genome Atlas the areas of overlap and difference with conventional clear cell kidney cancer. And in the future, our clinical trials will hopefully evaluate treatment strategies that target the unique biology of each subtype.